Welcome to the webinar, Lobular Breast Cancer, Understanding the Subtypes and Its Treatment. I'm Christine Benjamin, the Breast Cancer Program Director at SHARE. And before the presentation begins, I'm just going to tell you just a little bit about SHARE. We're a national nonprofit that improves the lives of women affected by breast or ovarian cancer through experienced peer support, accessible education, and innovative outreach, always for free. We meet women where they are, and especially in medically underserved communities, with the insight of women who have been there too, creating a nationwide network where women are empowered to feel less alone. SHARE's free services include support groups, educational tools, expert-led webinars and presentations, a national helpline, online communities, and survivor patient navigation. For more information, you can visit our website at sharecancersupport.org. So during the presentation, all participants will be muted. When the presenter finishes speaking, we'll open up for question and answers. You're welcome to submit questions during the presentation through the question pane in the control panel on your screen. When asking questions, please remember that the presenter is unable to give specific medical advice, so please keep your questions general in nature. The webinar is being recorded and it will be available soon on the SHARE website. So I'd like to introduce Dr. Otto Metzger. He received his MD in 2003 and completed training in internal medicine and medical oncology in 2008 in his native country, Brazil. He later spent 3 years in Brussels, where he completed a research fellowship and initiated a career dedicated to understanding the biological features of the second most common histological subtype of breast cancer, invasive lobular carcinoma. Since joining the breast oncology program at Dana-Farber Cancer Institute in 2012, he has established an active clinical practice and developed research efforts focused on identifying better treatment strategies for patients diagnosed with breast cancer. He's involved in designing and leading national and international clinical trials with a strong translational component. In addition to his physician and clinical investigator roles, Dr. Metzger holds an executive officer position at the Alliance for Clinical Trials in Oncology. Joining him today is Lori Petiti. She's a former television and documentary producer who helps coordinate the Lobular Breast Cancer Alliance with VP. Lori's interests include research advocacy, mentoring newly diagnosed patients, and raising awareness on the unique aspects of lobular breast cancer. Welcome, both of you. Dr. Metzger, we're going to turn it over to you and make you the presenter so that the audience can see your screen.
So, hi everyone. My name is Otto Metzger. I'm a medical oncologist at the Dana-Farber Cancer Institute in Boston, and it's my pleasure to participate on this webinar. First of all, I'd like to thank you, the SHARE organization, for this invitation and the Lobular Breast Cancer Alliance. So, the topic of this presentation is invasive lobular carcinoma, and the question here is if this is really a different disease from a clinical standpoint. So my second slide, you can see my disclosures. So in terms of how this presentation is structured, we're going to try to understand how we see lobular carcinoma from a clinical perspective. And when we think about lobular carcinoma, we always have to think about subgroups and how to interpret subgroups. So before going into the subject of lobular carcinoma itself, I would like to discuss a little bit and briefly about subgroup analysis, its definitions and challenges, the need for replication of findings, and how this is important for lobular carcinoma itself. So here on my fourth slide, we have a definition of subgroup analysis, which for our purpose here could be defined as an evaluation of treatment effects for specific endpoints in subgroup of patients according to baseline characteristics. And this could be biologically motivated. In our case, we have invasive lobular carcinoma. And when we look at subgroups, we should always try to get a sense of what's the consistency among the different subgroups that we're looking at. And just briefly here, in terms of definitions, when we think about subgroup analysis, we have to understand a concept that's called heterogeneity. This is a statistical concept, and it's basically some statistical assumptions that allow us to compare the magnitude of treatment effects in complementary subgroups. So this could be quantitative in terms of a quantitative heterogeneity, meaning that one treatment is always better, but by varying degrees, or a qualitative heterogeneity, where one treatment is better in a particular subgroup, but worse or not different in another subgroup. I know that this is very contextual, and I'm going to show you some examples so we can understand this better. But when we think about heterogeneity and the interpretation of subgroup analysis, we should always look for one specific test, which is a statistical test for interaction. So this is important. And here I have the SOFT trial, which is not a study that is dedicated to patients with lobular histology, but this gives us an example about how to interpret subgroup analysis. So SOFT is a clinical trial that included patients with early stage breast cancer that had their surgery, and patients were randomized to receive three types of intervention: tamoxifen monotherapy, tamoxifen in addition to ovarian function suppression, or exemestane, which is an aromatase inhibitor in combination with ovarian suppression. So here we have the top line results of the study, basically showing in the blue and red curves the superiority of the ovarian suppression containing arms when compared to tamoxifen for the overall population. But here in the initial publication, in the seminal publication of this study, we have an evaluation of subgroups, and here we have multiple subgroups listed. We don't have the histology, which is the topic of our interest today, but this is an example that when you have multiple subgroup analysis, we should always look for this p-value for interaction here, which basically tells us, allow us to interpret subgroups in the appropriate manner. And just quickly, considering we're talking a little bit about a dry issue here, which is statistics, when we think about subgroup analysis, we should always remember one different concept that's called the multiplicity. When we perform multiple subgroup analysis, the probability of false positive includes with the number of subgroup analysis conducted. So if one look at 10 subgroups out of a clinical trial, you have at least 40% of chance of having one of these findings as being false positive. In other words, you could see a statistical significance in terms of a p-value, but this could be a false positive. So just to wrap up this initial phase and some points for consideration here when interpreting the findings, clinicians should always ask if these results are valid and if these results are generalizable to their patients or really relevant for their clinical decisions that they have to make. But we have to remember that not all treatment decisions that we take or that we do on a regular basis, they're not always based on data from randomized clinical trials. And we need to improve on the use of multiple data sources for treatment decisions. And at the end of the day, we need the following. Here's what we recommend and why this is recommended. And this is particularly important for lobular carcinoma because we feel that this is a different disease, but basically we don't have large clinical trials or we don't have clinical trials at all looking at invasive lobular carcinoma as a separate disease subtype. But we know that lobular carcinoma is common. Lobular carcinoma by itself has a frequency that's similar to brain tumors or multiple myeloma altogether. And as I said, it has not been studied as a separate breast cancer subtype on clinical trials. So the first question here that I have is about what to do for patients that had an early stage invasive lobular carcinoma. And we note that these are usually breast cancers that express the estrogen and progesterone receptor status. So we'll talk in a minute about the role of endocrine therapy, which is very important for these patients. But one question that remains still a matter of debate today in 2019 is whether these patients should be treated with adjuvant chemotherapy, and if so, how can we identify the subset of patients that might benefit from chemotherapy? But in the literature, we have data, and these are retrospective series indicating that there is no overall survival benefit with chemotherapy for lobular carcinomas in general. So here we have the Netherlands a cancer registry, data from a cancer registry from Holland with close to 4,000 patients, showing that chemotherapy didn't add much in terms of benefit for these patients. The same was seen in the California Cancer Registry with 4,000 patients. A third were treated with chemotherapy in addition to endocrine therapy, and there was no survival benefit with the addition of chemotherapy for these patients. And my question is, are we really comfortable with this idea that none of the patients diagnosed with lobular carcinoma should be treated with chemotherapy, or we should be more careful here and try to look at the specific subsets and see if there is maybe a tiny minority of cases that could benefit from chemotherapy. So when we go back into the same series that I just mentioned, we could see that 11% of these cases, they had what's called a histologic grade 3. And histologic grade 3 in general is an indicator when we're looking at the tumor characteristics. It's an indicator of disease aggressiveness. And these are patients that in general, when we're talking about ER-positive disease, these are patients that could benefit from chemotherapy. And in these manuscripts, when they compared just histologic grade 3 versus 1, they saw that these patients had a worse outcome that was statistically significant, but overall, there was no benefit for chemotherapy here. So my question is, are we missing on a small subgroup of patients diagnosed with lobular carcinoma that could potentially benefit from chemotherapy? And when we go back to multiple retrospective series that have been published just looking at lobular and how this disease can be described, we know that lobular carcinoma in general, they're predominantly classified as histologic grade 1 and 2. These are proxy of low proliferation features, but we do have a small proportion of cases with histologic grade 3, as shown in the previous series. If we look at publications that have genomic data where we have gene expression profiling from cases, we know that these cases are in the great majority classified as luminal A, followed by a small proportion of luminal B. And this luminal A and luminal B, in simple terms, it's basically the same as low histologic grade or high histologic grade, or low proliferation and high proliferation. And again, patients that have high histologic grade or high genomic features are patients that in general could benefit from adjuvant chemotherapy. And here in this series, we saw that at least 10% of these cases, they have a high histologic grade. And one point for consideration when interpreting this retrospective series is how to interpret the data in a way that could be clinically meaningful. I think that to jump into the idea that none of these patients should benefit from chemotherapy, it's a bit risky because of what I've just said about the histologic grade. But we really need to learn a bit more about the disease biology and how lobular carcinoma really behaves. And we talked a little bit about histologic grade which is always shown in all pathology reports. But for lobular carcinoma, we have to be a little bit careful about the interpretation of histologic grade because histologic grade by itself it's formed by three independent features, which are tubule formation, nuclear pleomorphism, and mitotic count. And what happens with lobular carcinoma, just because the way the cells grow and the way they look at the microscope, they don't form tubule formation. So one of the components of the histologic grade it's not really represented and it's not really meaningful for lobular carcinomas. So, and because of that, a lot of patients that would otherwise be classified as histologic grade 1, which is a favorable indicator, they don't have tubule formations because they are lobular, so they are classified as histologic grade 2. So it's important as a clinician to have this information in mind and always try to look at individual components of histologic grade. So I mentioned a little bit that genomic studies are important. They allow us to understand from a biological standpoint a bit more about the disease. And here in this slide, which is called a genomic grade index in invasive lobular carcinoma, this is basically the results, the summary of the results of some work that I have done in the past while I was in Belgium, where I took a series of close to 170 cases that had an invasive lobular carcinoma diagnosis, and we did a very comprehensive genomic profiling of these cases, just trying to stratify or to see how this disease could be classified using a genomic technique. So here again, what we're really trying to see is if we're able, with a more refined genomic tool, to identify patients that could have high genomic features. And again, those would be the subset of patients that could benefit from chemotherapy. So here, the first bar on the left, we have just the breakdown of histologic grades for 144 classic lobular cases. And as we know, the majority are classified as histologic grade 1 and 2. We had a small proportion of histologic grade 3. When we looked at the genomic grade classifier, which is basically it's one of the genomic signatures that we used, we could see that 16% of these cases they had a high genomic risk. So here we're limited to see or to prove that those patients should benefit from chemotherapy, but this was a striking finding in the sense that there is a significant proportion of cases that could be reclassified as high genomic grade. And on the right, we also looked at a very rare subvariation of lobular carcinoma, which is called pleomorphic lobulars. And we see this as being slightly more aggressive in terms of the distribution of genomic grade, having higher genomic grade features. And the curves on the right, we don't need to go in details about those curves, but here we're just looking at patients' outcome, and we saw again that patients that had low genomic features, they had better outcome, while patients with high genomic grade signature, they had inferior outcome in terms of overall survival. Again, just indicating that what we saw from a biological standpoint is reflected in long-term overall survival for these patients. So more recently, there was a publication using a genomic tool that's commercially available in the United States, and a lot of patients have access to that, and we use it routinely on our clinical practice. This is called Oncotype DX. So this is not incredibly different from genomic grade index, but it's a different gene signature. But again, this is also trying to stratify ER-positive breast cancer according to risk classifications and this is used to help us to identify those who could benefit from chemotherapy. So this is a retrospective analysis that included 7,000 women that had a lobular carcinoma diagnosis and for which the oncotype data was available. And what we saw here in the breakdown of histologic grades was again that 7% of these cases had a histologic grade 3. And when we look at the breakdown of the oncotype itself into low, intermediate, and high, we saw that 8% of these cases, they had a high oncotype score. And we know from data from very large clinical trials such as TAILORx that patients that have a high oncotype score in general are those that should benefit from chemotherapy, while those with low to intermediate scores, there isn't much benefit in terms of giving chemotherapy for these patients. And in this series here, a high oncotype score was independently associated with mortality. But when we looked at the graphics on the right side of these slides, the authors they could not demonstrate a separation of the curves in favor of chemotherapy for those with high oncotype. And one criticism here is the fact that although we have 7,000 women, we have just a small fraction classified as high oncotype. So again, we're talking about a small subgroup here, and seeing a negative finding in terms of benefit of chemotherapy here doesn't mean that this patient shouldn't benefit from chemotherapy. There could be a benefit, but this is just missed because we're talking about small numbers, a small number of events, so we don't have the statistical power to see a difference in subgroup analysis, but these are important findings. So in summary, to wrap up this conversation about adjuvant chemotherapy for patients with lobular carcinoma. So approximately 10% of lobular tumors are classified as high risk by a combination of histologic grade or genomic tools. The components of classic histologic grade are very important. We should always take into consideration the lack of tubule formations. And I would say that retrospective series, they are underpowered from a statistical standpoint to reliably demonstrate a benefit of chemotherapy for this small proportion of patients. But I think that a combination of all that I've just said, in addition with tumor size, nodal status, we as clinicians, we have enough information in our hands today to identify who are the lobular patients diagnosed with lobular carcinoma that should benefit from chemotherapy. And this idea that lobular carcinoma should never benefit from chemotherapy, it's not necessarily true. So I want to move forward and hear a little bit faster for a second question that's a little bit less complicated, but also very interesting. And this in somehow has generated a lot of interest in lobular carcinoma. And this question is lobular carcinoma a breast cancer subset that being estrogen receptor positive disease should benefit the same way for the available endocrine therapies? And here we're talking about very common and old drugs like tamoxifen and letrozole. So a few years ago, we conducted this retrospective analysis on a large clinical trial with 12 years of median follow-up, which is the BU19080. This is a study that compared tamoxifen to letrozole for patients that had treatment for the early stage breast cancer. We have large number of patients, close to 5,000 patients included in this analysis. We compared lobular to ductose, and considering that these diseases, they have differences in the amount of high proliferation, or there is an imbalance in histologic grade, as we just mentioned. There is an imbalance in proliferation measured by gene signatures. So what we did in this big 19080 analysis was basically use one pathology marker as a way to control for these differences. This was basically done to adjust for the comparison so we could have a more reliable results and be able to interpret it better if there was any difference between tamoxifen and letrozole. So here we have these curves. This is usually how clinical trials are reported with these Kaplan-Meier curves. Here we have just the cases that had a histology named ductal carcinoma, which is the most common breast cancer subtype. And we see here on these curves that patients with ductal carcinoma treated with letrozole in the blue curve, they had better disease-free survival outcomes, or they did slightly better when compared to tamoxifen. So the separation of the curves indicates the superiority of letrozole for these patients. When we saw the curves for the patients with lobular histology, we're shocked because we saw that the lobular cases treated with tamoxifen, they had a much inferior outcome than the remaining subsets. We can see here in the dashed red lines that the lobular cases treated with tamoxifen, they had an 8-year disease-free survival of 66% when compared to 82% when treated with letrozole. And if you look on the right side of this slide, you can see here, as I mentioned before, the important interaction p-value, which is showing that the magnitude of benefit of letrozole for the lobular subset is much higher than the ductal subset, and it's statistically significant. So here, quickly, we have the curves for overall survival for the ductal subsets, and the same was observed for the lobular subsets. Inferior outcome when treated with tamoxifen with a significant interaction p-value. We try to control for the variables that we call proliferation, or this luminal A-like and luminal B-like. And for the lobular subset, no matter the subclassifications, they did better with letrozole. While for the ductal cases, they did better with letrozole if they had luminal B-like features, which is a matter of a different presentation because this is just showing that tamoxifen could be a good drug for a lot of patients that had an invasive ductal carcinoma and features of low proliferation, while letrozole seems to be a better drug for lobulars regardless of proliferation. And here, this is just a statistical testing. It's a multivariate analysis for disease-free survival, and we saw the same for overall survival. So considering these findings were unexpected, here we're talking about a retrospective analysis, we decided to go back to the forearm of the study just to look at the same question. We're just trying to get more information here about these patients. So the forearm option of this study includes 6,000 women. And here we don't need to pay attention to the numbers, but just to the shape of the curves. And when we look on the right side, which include only cases with lobular histology, we see a separation of the curves among those that were treated with letrozole-containing arms. So one more time indicating that there seems to be some difference between tamoxifen and aromatase inhibitor for patients with lobular carcinoma. So the previous slide was disease-free survival, and here we have the same for overall survival. We're intrigued by this finding. We didn't know if this would be true if looked at different studies, and our colleagues from Austria, they did the same type of analysis in a clinical trial called ABCSG8. This is a study that had a smaller sample size and included patients with lower risk than BQ19080 and had a slightly different design. Patients were treated with tamoxifen or tamoxifen followed by anastrozole. And their results were basically suggesting improvements in overall survival for the lobular subset when treated with the aromatase inhibitor containing arm. In this case, we have anastrozole, which is a very similar drug to letrozole. But the questions that still remain are, these are all retrospective series. They have limitations. But one could say that with letrozole and tamoxifen both being approved agents for postmenopausal women, one could consider using these drugs preferentially for lobulars as opposed to ductals. We saw a quantitative heterogeneity of treatment effect. There were significant p-values for interaction here. But the burning question that we don't have an answer yet is what are the biological mechanisms related to tamoxifen resistance? So there were studies that were conducted through collaborators in Pittsburgh looking just at lobular and ductal cell lines. In here, we don't need to go over these graphics and try to understand their meaning or what they are telling us, but this is just showing that lobular, when we use preclinical models with ILC cell lines, we saw that these cell lines, they were partially resistant to tamoxifen. So again, here we're going to the opposite direction. Instead of looking at preclinical findings and going to the clinical setting, we went back from the clinical findings, trying to understand in the lab what was happening using initially cell lines. And this has also informed us or has motivated us to design this clinical trial, which is ongoing at the moment for about 2 years at the Dana-Farber and a few other centers in the US. This is the study PLOPS, that basically it's one of the first clinical trials that have been designed to answer specific questions for the lobular histology. So this clinical trial including patients that have either a diagnosis of lobular or ductal carcinoma. They are treated in a window phase with tamoxifen or letrozole, and we have mandatory research biopsies at 2 time points. So we're grateful that we have a very large number of patients enrolled so far. Patients were very nice in contributing these research biopsies, which are going to be, we hope they're going to be useful for us to understand what are the real biological underpinnings for this comparison of tamoxifen and letrozole. But of course, we expect to learn more than just this clinical question and understanding more a little bit about the biology of the disease. And the study doesn't end after this initial window phase or this short exposure to therapy, but patients are treated with a full course of neoadjuvant or endocrine therapy that's given before surgery with letrozole or letrozole in combination with a very promising drug called palbociclib. So palbociclib, just briefly, it's a CDK4/6 inhibitor that's being studied in large clinical trials, and there is a large expectation that this could be the new standard of care in the near future for ER-positive disease. So here we want to have data about how this drug behaves among patients diagnosed with lobular carcinoma as well. So just briefly here, sometimes we hear about cases of lobular histology that are classified as HER2-positive disease. This is extremely rare. So lobular carcinoma accounts for 10% of breast cancers, and we have about 3% of all lobulars being classified as HER2-positive disease. So here is just a list of different series that have looked into that. And it goes from, as I said, it's about 3% of these cases. When we have a case of HER2-positive lobular carcinoma, we should always discuss with our pathologist to make sure that this is really the case. So here I have a case of mine that we got this result as being HER2-positive disease. This picture is just a picture from pathology with in situ hybridization showing HER2 amplification. But when I discussed with the pathologist, I saw that the HER2 amplification was not in the invasive lobular carcinoma itself, but it was just on the in situ component, which is different. But there are cases, so I'm showing this here just to alert that, as always the case, once we have rare cases, we should always be careful and try to discuss in more details. But for cases that are really HER2 positive and they have the lobular histology, the question is, should we treat these patients as HER2 positive disease and give them a course of anti-HER2 therapies, which usually goes along with chemotherapy, So we used data from the HERA trial a few years ago just to look into this question, comparing the outcome of patients with lobular and ductal histology, all HER2-positive disease. And here, we're limited by small numbers, but what this data is showing us is that if you have a lobular carcinoma that's HER2-positive disease, this should be treated in the same way. And again, I just want to point to the p-value for interaction, which, as I said at the beginning of this presentation, that this is very important. And this p-value here being negative, it's basically showing us or telling us that there is no significant difference between the ductal and lobular cases here, despite the small numbers. So in this, we're looking for disease-free survival, and the same was true for overall survival. So I would say that in conclusions, before we open for questions, I'm in favor of conducting subgroup analysis, and I think that they can lead to informative results, but they can also lead to results that could be dangerous because a subgroup analysis, if it's overinterpreted, one could say that none of the lobular cases should be treated with adjuvant chemotherapy, or that all cases should be treated with XYZ. So it's very important to be critical of the data and to avoid misleading clinical indications. Validation of findings is always very important. One subgroup analysis by itself could just be a false positive result, so we should always look for additional data. And I would say here, this is a little bit of my bias. I think that invasive lobular carcinoma, from a clinical standpoint, it's a distinct breast cancer subtype. We could talk for hours and hours about how this disease is different, not just in terms of the treatments that we discussed, but this is a disease that's different the way it presents in the mammogram. It's different the way it grows. It's different the way we try to evaluate the surgical margins, the indications for mastectomy versus lumpectomy. So there are many, many differences. And it's a disease that, unfortunately, when it relapses, we still know very little about how to treat this disease, despite the fact that we have tons of data indicating that this goes into distant sites of our body. So there is still a lot of research to be done. So with that, I'm going to open for questions, and thank you so much for your attention.
Thank you, Dr. Metzger. So before we just open for questions, we're going to hear from Lori Petiti, the co-coordinator of the Lobular Breast Cancer Alliance. And Lori, we are trying to do the presenter, which we have. Great.
Hi, thank you. Thank you very much, Dr. Metzger, for a great presentation. I think you just showed kind of the reason the Lobular Breast Cancer Alliance exists is there's a lot of things to learn. And our mission is to increase our knowledge of lobular breast disease, advance diagnosis, treatment, and follow-up care for patients. We are a volunteer, patient-driven organization. We formed from the first International ILC Symposium that was held in Pittsburgh in 2016. Since then, we've built our foundation on providing quality information to the community. We have a steering committee from patients from around the country, and we've recruited a top scientific advisory and editorial board, including Dr. Metzger. We have a website, a newsletter, we engage in social media, and currently we have a survey on our website that I would encourage everybody to fill out. It will help us improve our website content and get a feel of what kind of information that you as patients and advocates are looking for. We've participated in webinars such as this, and we continue to look for partnerships that can fill the gaps on our knowledge of ILC. Our members are active in organizations such as the Metastatic Breast Cancer Project. We're a member of the Metastatic Breast Cancer Alliance, and several of our members volunteer to mentor lobular patients for SHARE. A top priority is engaging the scientific community to further research and educational opportunities. Many of us are project lead trained, and we've served on DoD peer review. And our top research focus, as Otto has explained to us, is understanding the unique biology and behavior of ILC and how we can use this information to increase targeted therapies. ILC is not well understood, and the treatments follow the general standard of care. We feel that there are some attainable opportunities, such as refining therapies, advancing targeted therapies. Imaging can be a challenge for ILC. We would like to see valid, reliable screening and imaging tools that lead to better detection and better surveillance for recurrence and improve imaging of metastatic lobular disease. There's also a big need to develop basic tools to support research, such as cell lines and tumor banks. And there's an opportunity to integrate ILC specific outcomes into the objectives of appropriate large studies and clinical trials. As advocates, what can you do? Well, honestly, the first thing is improve patient education. We have information on our website and such things as frequently asked questions, fact sheets about lobular. We've just posted a new infographic on potential sites of metastases, and it's designed for patients and caregivers both. You can raise awareness at your breast cancer organizations, events, conferences, meetings, and research institutions. We look to develop the tools and contacts that can impact the conversation. I encourage you to please visit our website and sign up for our newsletter. And kind of the most exciting thing coming up is we will have a second International ILC Symposium in Pittsburgh in 2020, co-chaired by Drs. Steffi Ustrich and Otto Metzger. There will be a research intense focus and many opportunities for advocates to learn and engage with researchers. So thank you, Cher, for allowing me to introduce the Lobular Breast Cancer Alliance. Thank you, Dr. Metzger, for your continued support and work on ILC. And I want to do a special shout out to Lee Pate, who's the leader of our steering committee and really a driving force of the LBCA. Thank you.
Thank you,
so
Lori.
much.
Lori, do you have a question that you'd like to ask?
I do. Sorry. You know, one of the questions that we continually get asked on the website from patients is about chemotherapy. And Dr. Metzger, I think you did a wonderful job of explaining what patients' chemotherapy may be good for. But if you could just recap that, because I think it's really important. And I do want the audience to know that we're working on a Q&A with Dr. Metzger specifically on chemotherapy that will be posted on our website in the near future.
So the chemotherapy question, it's still a matter of debate, and this annoys me a big deal because we're talking about large number of patients diagnosed with invasive lobular carcinoma, and we get different messages from different places about the value of chemotherapy. And I think this doesn't need to be that complicated. So if someone has a very tiny invasive breast cancer in general, the value of chemotherapy and the gains with chemotherapy are really, really small. And there is probably no value for chemotherapy for tiny cancers. But if you have slightly larger cancers, sometimes one with 1 to 3 positive nodes, these are the cases where we oncologists, we got a lot better about deciding who should get chemotherapy in general, but we need to do a better work for patients that have lobular carcinoma. So one tip that's important, it's always to take a look at the histologic grade breakdown. Lobular carcinoma that have more aggressive features usually have high mitotic indexes. The interpretation of the genomic tools like MemmaPrint and Oncotype, they have to be done in a slightly different way. We need to make sure that the samples that were sent for testing included a fair amount of invasive disease, so we know so we can interpret the result that we're getting back. And we should always remember that about 10% of these cases they have characteristics indicating that there should be a benefit for chemotherapy. We would never have data from very large clinical trials answering this question specifically because we just don't have numbers enough. But my idea is really to try to do the same that we did for the HER2 positive lobulars. We look at specific subsets and we see how this behaves in relation to large sample sizes, and so it shouldn't be too complicated.
Great. Another question that's been asked is, for premenopausal women, should they do ovarian suppression and an aromatase inhibitor, or should they stay on tamoxifen until they go through menopause?
So this is a very difficult question, and I get this question on my inbox at least once a month. And the correct answer is we still don't know. Tamoxifen is a drug that, as far as we know, it's very effective in general. There could be cases where you have a diagnosis of lobular carcinoma in the premenopausal setting, for which where there are features of more aggressiveness or larger tumor sizes where the addition of ovarian suppression would make sense. There is no recipe that applies to all patients here. And if this was a question in an exam, let's say to a board, the answer would be tamoxifen to everyone because that's the data that we have. But based on all the information that we've been gathering so far, I think there is a space here to individualize, and some patients, they might benefit from an addition of ovarian suppression to either tamoxifen or letrozole. So ovarian suppression by itself is an effective form of endocrine therapy. And if you have a partial resistance to tamoxifen, let's imagine that also applies to the premenopausal women, maybe just adding the ovarian suppression with tamoxifen, we would be achieving most of the benefits with endocrine therapy. One could say that this could be even better with the combination of ovarian suppression plus aromatase inhibitors, but when we do that, we have more toxicities in terms of menopause-related symptoms.
Great, thank you. Is there a difference between the 3 aromatase inhibitors? Is one better than the other? Are there pros and cons?
So they're basically equally effective, and they have been tested in large clinical trials in postmenopausal women. So head-to-head comparisons have demonstrated that they're equally effective.
Great, thank you. You talked a little bit about tamoxifen and ILC sometimes being resistant. Is it possible that ILC can also develop a resistance to an aromatase inhibitor?
Yes, so that's a possibility, and we're still learning about what could happen in terms of resistance to aromatase inhibitor. We know that for patients with advanced disease, once they're treated with aromatase inhibitors, for both lobulars and non-lobulars, they develop at the time of resistance mutations in the estrogen receptor. This is ESR1 mutations. In the early stage disease, the significance of that it's still unknown. But it's a possibility.
Great. You talked a little bit about the CDK4/6 inhibitors and studies going on now. In your opinion, do you think they're a good choice for ILC in early stage? And is it possible to even prescribe that now for early stage lobular patients?
So there's a lot of enthusiasm with these drugs, but they shouldn't be used until we have the results. They shouldn't be used outside of clinical trials until we have the results of large phase 3 studies that are going to be able to demonstrate if these drugs are really effective in early stage disease.
How long do you think that will take? How much longer, I should say?
So I don't think that would take that long. So I'm highly involved in one of the large adjuvant studies, which is conducted through Alliance in the United States in collaboration with the Austrian Breast Cancer Study Group in Europe. This study is named PALLAS, and it has completed enrollment with close to 6,000 women participating.
Great. And PALLAS breaks out ILC from ductal as a subset for reporting?
So it does for reporting, and I'm working on a proposal at the moment to look into this with more precision than what's being collected.
Great. You mentioned the Oncotype DX test, and you had some facts and figures for the lobular subset of that. Is this the standard in terms of genomic tests for ILC, or is there something else out there?
So there are a number of tests that could be used, and Oncotype is the test that's more widely used in the United States because of the reimbursement rules. I don't feel strongly about any of these tests. I think that they're all valuable tests. And one of the problems with Oncotype is the fact that we still don't have the histologic breakdown for the large clinical trial with evaluating the role of Oncotype, which is TAILORx. So I'm in touch with the investigators that conducted this trial and trying to make this happen, but this was not collected prospectively on TAILORx.
Great, that would be really great. Can you tell us a little bit about the role of chemotherapy and endocrine therapy in metastatic disease?
Sure. So for patients with advanced lobular carcinoma, endocrine therapy and remains as a very important component of treatment. We don't know if this is really different from invasive ductal carcinoma, where if you have an ER-positive disease, they are also treated with endocrine therapy. And we don't know much about chemotherapy in general for these patients. But we conducted an analysis, and this is a recent publication, just comparing what the outcomes of patients that had been exposed to multiple lines of therapy before being treated with a single agent chemotherapy called eribulin. And here we use this data just because it was data from clinical trials, and there was no interest in eribulin itself as a better or worse option for lobular, but the idea here was basically try to compare the outcome of lobular and ductal patients that had been previously exposed to multiple lines of therapy, and we saw no difference. These patients, they had a very similar behavior when treated with this chemotherapy. And this, it speaks for the fact that the disease changes a lot over time, and if you have an advanced breast cancer that has been exposed to multiple lines of therapy, this is very different from the initial diagnosis.
Great, interesting.
Lori, I have a question that came from online, if you don't mind. Since metastatic lobular breast cancer goes to parts of the body, like the ovaries or the stomach, how should patients be followed? Many oncologists will only scan a patient if they report symptoms. Yet, as in the case of ovaries, for example, patients may not feel symptoms right away.
So this is a very important question, and the answer is there is no value in doing scans to try to look for disease progression in breast cancer in general. And the reason we have this recommendation is because there were studies done in the past showing that the scans or additional images, they don't increase they don't improve on outcomes. Patients live the same. And unfortunately, what happens is if you had a disease that had spread outside of the breast to a distant site, diagnosing it with a very precise image a few months before rather than a few months later when symptoms develop, this doesn't interfere on the chances that this specific patient would live longer. So patients, they basically live the same. So we basically have to go by the current recommendations and speak against excessive imaging for follow-up of breast cancer patients in general, because patients, they don't live longer if we do these additional images.
So thank you. It is 2 o'clock and it is time to wrap up. We just wanted to let people know of some upcoming events that you might be interested in. So there's a topic-driven roundtable on lobular breast cancer, and that will be facilitated by Lee Pate and Elizabeth Vigiano of the Lobular Breast Cancer Alliance on August 28th. And you can sign on through sharecancersupport.com, and also a roundtable for DCIS coming up the end of this month, May 29th. There were over 140 participants in today's webinar, and there are a lot of questions that were unanswered. So what we might do is send some of the questions to Dr. Metzgar, and I'm sure you're not too busy to answer several questions that came in, and if we're able to do that, then we're happy to email everyone the questions and the answers. Also, if you don't mind taking a moment at the end of the webinar to fill out the survey, the evaluation, we would really appreciate that. So thank you so much, Dr. Metzgar. It's been really informative. Thank you to the Lobular Breast Cancer Alliance and all the work that you do. And thank you to all the participants.
Thank you so much.
Thank you, everyone.
Thank you.
Bye-bye.